everybody. Welcome back to Psychedelics Today. This is going to be a fun one. I haven't hosted 3 guests in a bit, but we've got Lynn Watkins, CJ Spotswood, and Court Wing. How are you all doing today?
Great.
Fantastic.
Doing well.
Great. CJ, what is it? The Way Life Should Be, Maine?
The way life should be, exactly.
That's great. So today we're here to talk about chronic pain and psychedelics, and we're going to have a story shared about Lynn and Lynn's shifting from a pretty intense pain state to what looks a lot like remission. So let's kind of get into it. Lynn, could you kind of set the stage with a bit of a story about what you were experiencing before?
Sure. A little over 20 years ago, in July actually of '03, I had surgery on my shoulder, and during that surgery, I was strapped to a table where the seatbelt was apparently placed in an improper location, or somehow was pinching my right femoral subcutaneous nerve. And over the 2 hours of surgery, that severed that nerve. Many nerve conduction studies over the years have said that. So I woke up a few days later with some pain. No problem, it's going to regenerate. Weeks, no problem, it's going to regenerate. Months went by. I finally went to a pain management. They figured out that the strap had in fact severed that nerve. That started my world of CRPS, or complex regional pain syndrome, which just feels like there's either a red hot poker stabbing me in the right thigh is where it started, or felt like it was on fire. And at times it would change to being like plastic feeling or numb or tingling, but there would be oftentimes I'd have a sharp pain go through my leg, and I just instantly would grab for my thigh and try to push it away, just rub it and push it away to make it to stop. And it would for minutes maybe, but that spread over years to I ended up with my diagnosis now is, or has been, CRPS type 2, and based on the injury, and full body with brain inflammation. So along with the CRPS, I developed what's called glossidynia, which is burning mouth syndrome. That came around 2009. In early 2000s, I had foot surgery for a plain old bunionectomy, and that ended up with 4 surgeries over 4 years that left me with 2 Morton's neuroma on the bottom of my foot and inability to move only my great toe, only my large toe. I could not move the other 4 toes, so balance became a horrible issue. I was falling before I got involved with court and REMAP. Probably I could say I stumbled every day, had good hard falls probably once a month or 6 weeks. And I mean, to the point of cracking teeth, getting, knocking myself out, landing flat on my head. Some pretty good falls. And also had 2 surgeries on my right hand that left I could not, even after those 2 surgeries, I couldn't use my right hand to hold on to things, was dropping coffee cups, that kind of thing. It was just, it continued to get worse and worse over the years. It seemed like anything that I got that was negative, I got it really bad after the CRPS set in. And I tried so many medications, so many therapies. I had a spinal cord stimulator implanted, had 2 surgeries after that to fix it and then to take it out. Nerve ablations, dorsal rhizotomies, one medication called Trileptal put me in the ICU at Walter Reed for a few days because it was depleting my sodium. Another medication, amitriptyline or nortriptyline, both of those, caused me to have significant chest pains that lasted for approximately 2 years after I got off that medicine. It's not been fun at all. It's been horrible to do my job. I was retired from the military, because of all that I was going through. The medical appointments got to be too much, and I was a military judge when I retired. And to lose that role, which is like the capstone of, in my opinion, of an attorney's career in the Air Force, except for obviously the Judge Advocate General of the Air Force, to lose that and have to walk away was probably one of the hardest things. And I ultimately, because of all the pain, I was having cognitive issues, and I actually surrendered my law license because I wasn't able to. I couldn't imagine practicing law again. Now I kind of regret it because I think I could.
Thanks, Lynn. And were you receiving ketamine injections monthly for a while too?
I did right after retirement. I received ketamine for probably about 6.5 years. 3 different doctors, first in Atlanta, then in Tampa, and then here locally in Destin, or semi-locally. That involved pretty high doses of ketamine, of up to 1,200 or so. I don't know what to say as milliliters or whatever, but where I just basically walked in, took my infusion for 4.5 hours, and was wheeled out because I was under Versed. I was out for the treatment. No therapy, no talk to anybody. I started seeking. I did seek mental health therapy while on active duty, which is very difficult for anybody who's ever been in the military to consider doing. I had a colonel mentor of mine that talked to me, and if she could go, then I decided I could go. And it's from that point, about 2009 or 10, I was started on depression medications and anxiety medications, and um, so. But the ketamine, then to get back to the ketamine, sorry, it just was. I was going every 3 or 4 months to then once a month, and that's $1,200 per infusion where I went, and insurance not covering that, starting to have other issues with my body, and thankfully, a good friend of mine sent me to court, and it's been just nothing but. I mean, I can't say enough positive things about how my life has changed over this journey since last July. Actually, last March is when I met CJ in court with our preparation to begin this journey.
Thanks for that. And where do we want to go from here? Court, do you want to talk about, well, I guess for those of you who don't know, which most of you should if you're listening to Psychedelics, say Court Wing's been around for a bit. We've been collaborating on this pain and psychedelics topic for a number of years now, and also co-founders over at the Psychedelics and Pain nonprofit, and psychedelicsandpain.org, where there's a big free course with the latest in psychedelics for pain. But yeah, Court, where do you want to start?
Thank you, Joe. And we do encourage everyone to please go visit the Psychedelics and Pain Association. That's a co-founded project between Cluster Busters, Psychedelics Today, and REMAP Therapeutics. Our online course features the top researchers around the world discussing the latest study research that's emerging in this field. And it's a high-level overview aimed at clinicians and practitioners so that you are well suited to discuss this with patients, or if you are someone who is in pain and is possibly seeking how to employ this remedy into your care team's treatment approach, strongly urge you to take a look at that. And CJ Spotswood, our principal psychiatric clinician, also has written a book called the Microdosing Guidebook, the second half of which is full of studies, bingo, full of studies specifically aimed at general practitioners, allowing them to see why these drugs are as, efficacious as they are. So, very quickly, I swear to God, I was a study participant in NYU's psilocybin trial for major depressive disorder in March of 2020. I was experiencing an increasingly treatment-resistant episode that had lasted for at least 5 years. By the end of my dosing day, I was in complete and full remission. shockingly, I was also in complete and full remission from what had been a also 5-year bout, at least, of low to moderate chronic pain. And it was my big secret since I was a professional in the performance and pain field, having worked with thousands of students, hundreds of clients over the year through several interdisciplinary approaches. At the end of the day, I'm in full remission. The next morning, I'm lying there and I say to myself, with this degree of neuroplasticity and visual field interaction, why couldn't you combine this with mirror box therapy to treat phantom limb pain? I thought I'd found something completely new. I rapidly found a study on from Japan in 1962 by Kuromaro et al. Using low-dose LSD to treat phantom limb pain. But I thought the mirror box was a unique innovation. Within 2 months, Dr. Joel Castellanos of PHRI at UCSD released a position paper, Chronic Pain and Psychedelics, a review and proposed mechanism of action. Within that paper is a discussion of how V.S. Ramachandran and Albert Lynn, limb loss survivor, treated successfully his severe intractable phantom limb pain using high dose psilocybin mirror box therapy. So since then, all that I've pursued, starting with you, is founding REMAP Therapeutics and really doing our very damnedest to promote the fact that we have a solution out there that has this broad transdiagnostic efficacy across multiple pain, autoimmune, and inflammatory conditions. So, due to my background in applied neurophysiology and the advanced certifications I have there, I was already richly familiar with how to induce neuroplasticity, what creates nociplastic conditions for people that are in chronic pain, and that there was a need to bridge this gap between what has been largely an underground or an indigenous practice or a very, very sheltered niche locale within modern research. And that there is this need to bridge this gap with both the pain communities as well as clinicians out there and do our best to inform them how that these approaches can be merged.
That's amazing. Thanks. And CJ, I'm curious if you could share a little bit about when you were brought in to the conversation. What kind of thoughts or observations did you have?
So I've been working in psychedelics now for, going on 6 years, I'm guessing it must be. And um, actually, I believe you introduced me to Court, Joe. And in doing that, had said, I've got this idea. What do you think? And we just started talking back and forth. And, my specialty is psychiatry. I'm not um, a pain specialist by any means, but my background being in psychiatry, along with my background in nursing, along with uh, psychedelics, it was like let's kind of look through this. And I'd gone through between writing my book and my previous research and presentations on psychedelics, just seeing this um, little bit of information here and there about these miraculous improvements, like the Kumaro, the work by Dr. Cast, looking at LSD and pain, end of life pain, and hearing Court's testimony and what he saw. It was like, let's look into this, let's dig into this, and started kind of digging through all this research and just kind of going, I think you are absolutely right, Court. Like this is something that you know people are talking about, but it's not at the forefront yet, and people aren't really aware of it. Um, because when we started talking, it was well before even Lynn kind of came on board with this, and kind of like, where are we going to go? And very excited about having that opportunity to kind of figure this out as we kind of go along, and seeing these studies as we start doing it popping up, like Joel Castellanos' work, etc., are just popping up and being published as they are coming.
Amazing. All right. Court, can you share a little bit about when you started chatting with Lynn and what that was like for you?
Sure. So, as part of REMAP Therapeutics mission, right, we thought it was absolutely vital that we start treating people suffering from chronic pain now, not 10 years from now when the FDA approvals have gone through or all the studies are done, but that it had to be done now because we had organizations like Cluster Busters already out there that had been successfully treating people with among the most advanced pain conditions known to medicine, you know. And I'd been very fortunate to meet Bob Wold at the Horizons conference, but I had been, diving into the literature and just shocked at how much data was out there already showing this efficacy. And then you start talking to people with case reports, right, out there for other pain conditions, and it became overwhelming. And my direct experience was so clear. So we started reaching out saying, hey, we're going to do this retreat. Is there anybody out there that you think would be recommendable to us? And very fortunately, um, Kimberly Jarovieski from the Ketamine Task Force, which is an organization that's specifically organized around treating people with CRPS. And just to be clear, this is a devastating chronic pain disease, um, absolutely incapacitating. And it bears repeating, it's pain that we don't have a reference for in the general public. We just don't know this type of pain unless you know someone who has it or you're working in the field. And she sent me an email saying, hey, I think I might have someone for your retreat. So I was introduced to Lynn, and when you work in this field, you know right away, within the space of about 2 minutes, where someone's at. And it was so evident how much pain and suffering she was going through. And as the story developed, it's just one thing after a fucking another, where there's these just maybe they were good intentioned interventions, but they had all not gone well. And there was this cascade of injury and consequence. Um, and so I started kind of pouring through, okay, where did the initial injury happen? Where did it spread to? What interventions then perhaps magnified, right, this nociplastic state that was going on, and started trying to come up with what would be, a reasonable approach of neuromodulation based on the training I'd already had. And I want to make this clear. This has been a profound team and network effort from the start. Like, I was reaching out to James Close at Imperial College. I was reaching out to Professor Jan Rawmakers at Maastricht. I was routinely pestering, bothering, pleading, with Joel Castellanos. All of these people were doing this informally, but in support, and asking, is this crazy? Am I on the wrong track? And no, in the middle of that, PHRI published this amazing case series in Pain Journal, where it literally described our approach. So we had already set up our protocol. We had already launched our own online course, integrating neuromuscular rehabilitation with psychedelics. And based on our training already that we had, it was very clear what the approach should be, where you're trying to induce neuroplasticity into a client that's suffering from chronic pain, all the different types of neuromodulation, doing quantitative and qualitative assessments, in the receptor layers, their visual, vestibular fields, trying to discover what social and psychological stressors impact their pain, as well as, where are these sensory and motor deficits residing within the entirety of their nervous system, and what can we do to either bring them back on board and either upregulate some or downregulate the others. It's fairly involved. It takes a lot of time because neuroplasticity typically requires novelty and intensity in order for the nervous system to actually devote the metabolic resources to drive that change. So it was a lot of time over Zoom with Lynn, asking questions about her history, asking questions, and then doing assessments like live in real time, and then trying things out, seeing how she responded, test, reassess, right? And then intense conversations with CJ. So, REMAP goes through a screening process, whether or not this is appropriate for someone. And part of that is a psychological battery. As we know, there can be adverse events with people with certain psychological conditions that we all need to be mindful of. There's exclusionary criteria in modern clinical trials. So all of those are things that we're checking for. But after CJ and I interviewed her, and maybe this would be a time to hand this one off to him, it just became rapidly apparent that there had been a discussion of PTSD in the past occurring for Lynn, but it was clearly present and clearly a factor in outcome. And in fact, her case was complex. She had a very complex presentation, not just PTSD, not just glossodynia, not just severe neuropathic pain from the foot neuromas, right? But there's also PTSD present. There's also severe anxiety. There's also depression. All of those things were ongoing, and there was some relief happening, but the frequency of relief was the period of it, the duration was getting shorter and shorter. So, CJ and I made our initial assessments. Maybe you'd like to share there?
Yeah, I mean, even before we did the initial assessments, I remember having conversations with you, Court, before we even met with Lynn, and just kind of when you gave me, her backstory and kind of describing what we're looking at. I mean, I'll admit that we were both kind of hesitant to kind of, A, where do we begin and what are we going to be doing and what are we treating? It wasn't like there was a centralized one piece of pain that's going on. We have this complex regional pain that's going on, and it's in various places throughout the body, between the feet and the legs and elsewhere with that hypersensitivity. And the question is, how are we going to, what are we going to do for her? So when I first met with her, with you, we were kind of looking at, we're not going to make any promises if we're even going to jump into this, but let's get some baseline information and kind of look at what we're doing. And part of the screening, we did um, regular screening tools, MADRS and HAM-D, looking at her depression levels. We started looking at GAD-7, looking at anxiety, and um, the other challenging piece when it comes to Lynn's case is she was psychedelically naive. She had never used any of these psychedelic substances. Um, she did have that history of using ketamine, but with the ketamine that as she was using it, it was a anesthetic dose. Like there was no being awake, there was no talk therapy. It was under these conditions where it was literally just knocking her out, and the medicine was doing what it was doing. And I remember while we were looking at it, I remember asking Lynn a couple times, is there any trauma here? Are we looking at PTSD with some of the stuff that we've got kind of going on? And repeatedly, Lynn had reassured us that this is not the case. I really don't have symptoms of PTSD. I don't have any trauma. And really just kind of left it at that at this point. But in the back of my mind, I'm also thinking, as a broad generalization, I don't want to diminish individuals' experience, but from my experience, many people that have chronic pain that's going on, there is usually a connection there with that mind body, the psychological piece to it. But there's also a history of trauma many times people have that maybe they're not recognizing. And when I was looking at that and talking with Lynn, I remember I'd said to her after she denied it, I said, when using these substances, um, the medicine has its own agenda. Sometimes, literally shit can pop up and start bubbling forward that you don't even, might not even completely be aware of. Is there anything that, as we're sitting with you that might pop up that we can be aware of, that, as it's coming out, to kind of be there for you? And Lynn started describing some adverse childhood experiences, some experiences from the military, from her military service, and from uh, traumas from sitting on the bench as a judge and hearing other people's stories, and um, taking all of that in, that caregiver um, stress that she was taking in. And as we started kind of talking about that, I started asking her some questions about like her sleep patterns and her mood. And right away, I was like, let's explore this a little bit deeper. Um, so we ended up doing a CAPS, looking at trauma, getting a score of that. And her initial CAPS score was 54, moderate level of PTSD. And I remember, I don't know if you remember this, Lynn. I remember at the end of it, as I'm adding up all of these numbers, and I didn't have all the numbers in front of me, but everything was screaming. I go, Lynn, I don't know how to tell you this, but I believe that you have PTSD and no one's diagnosed you with this. And there's these things that are kind of, this is going on. Um, which then kind of opened up these more conversations of, well, yeah, I always thought it was kind of attributed to my pain, or is attributed to um, my mood and my depression as a result, never thinking of it as this. And and I don't you know don't think it was her being stoic. I think it was her experience was, I've dealt with these things and it's not really present, but they were. Um, so yeah, that was kind of the big thing. Like her HAM-D, we had a 22, which is a moderate level of depression. Madras was a 41 initially. So these numbers were significant that we had right there going into this. And then the other challenge looking at with Lynn, I guess I'll mention this, is her medication regimen that she's on. Um, she had various medications that she was on for physical and mental health conditions, one of which, the antidepressant medication that she was on, um, can be challenging for some people to stop. This medication specifically, if I'm decreasing or stopping it for one of my patients, I typically will do a taper, sometimes up to 3 months or longer. And looking at the timetable to work with her, it was like, we could do this and we might see, you know, a cascade of issues as a result of, mood would be worse going in. We can increase, the depression, the anxiety, increase potentially suicidal thoughts, the physical concerns because of, this SNRI medication also helps with pain for some people. And it was like, how do you want to go about this? Do you want to stop the med, which we can kind of have that discussion? We can talk with your provider. Because my role as clinician with REMAP is Lynn is not my patient. I'm consulting in with my recommendations for medications and working with her providers to kind of figure out. Or do you want to stick with the medication that you're at, and we can kind of look at like a boulder in the road and kind of work around it? Um, Lynn felt that she wanted to work with the medication that she was on, which then kind of opened up the conversation of, what are we going to do for dosing recommendations to kind of go about this?
One thing that I think bears emphasis here is that many chronic pain patients, and particularly those that have been going through the medical system for a prolonged period of time develop PTSD as well from that experience. That's something that Bob Wold at Clusterbusters repeatedly has stressed, is that a lot of people have no history of adverse childhood events, and as a result of developing clusters, develop PTSD. And that when they apply the CAP scores, there's a very clear demarcation line within the cluster community between those that have been using psychedelics to treat their cluster headaches and those who have not. And it's also important to emphasize these things can exist in tandem, right? You can have PTSD and you can have chronic pain, and they can be interrelated and they can be co-contributors, but they can also be completely separate factors within the entire cortical receptor loop. So they have to be considered as interactive, but as also separate issues to deal with uniquely on their own. So, one thing to um, stress here is, so we're coordinating, we're going through all of this, and we're getting ready to go, and we're rapidly identifying drills that she's responsive to or partially responsive to, interventions that we're going to use once we're in this neuroplastic window, and after, when this remapping period can start, right? So remapping is a term of art within the neurological and physiotherapeutic communities, and for various types of neurorehabilitation, where your brain is literally, much in the same way what we see with people that have severe depression. They have these entrenched, I think the phrase now that's being used is canalized entrenchment of these automatic, protective, but ultimately negative responses, right? So, in the same way someone with severe depression has usually a very negative worldview, both of themselves and their expectations, like, they're just saying that to be nice, I suck, nothing I ever do works out, maybe it would be better if I just ended it all, right? Um, that is something that is governed by the nervous system, governed by the cortex, right? And it actually encodes itself into the neurological structures. It's the same thing with chronic pain. You can be having all this bottom up sensory input that's trying to correct this pain output from the brain, right? This perceptual pain output. But that output is a protective response, and it can be so strong that it's very hard to get it to change, right? So a lot of what we're doing with these assessments and these interventions is trying to introduce the experience to our clients that, hey, we can make a difference in that pain perception. We can make a difference in that, local sensory response. We can make a difference in the motor response. It may not be for very long. It may not be complete, but it's there enough. And so you're priming this nervous system. Then we go and we introduce psychedelics within this constrained time period where we've done a ton of preparation, and then we're able to do very intense focused work. And we already have a scaffolding in place of things to do. So one of the we were visiting this last night, here we are 9 months down the road. And we were visiting like the first critical moment that this happened. One of the things we haven't mentioned yet is that because of the foot surgery, Lynn had no motor control, or maybe she did mention it, but Lynn had no motor control of her 4 smaller toes. Her bigger toe was operational, but her smaller toes, she could not move them at all. And that had been ongoing, I think, somewhere between 7 and 9 years. And maybe, Lynn, you can talk to us about what happened that day. This was on your first dosing day, and what
Right.
came out of that.
So from the 4 bunion surgeries, or one bunion surgery and 3 follow-up surgeries, they ended up taking the knuckles, removing basically the knuckles out of my foot, and so that made my toe almost look like this is what my foot looked like with the great toe. So I was, we'd been doing some drills and some work, and I just could not believe that when I looked down and I saw that a couple of my toes were moving, and then I purposely was trying to move them, and they were starting to moving, and I I broke down after. I think it was 2014 was when they took the knuckles out of my toes, and have not been able to use those. I could not move them, period. Um, and you go to physical therapy and you try to. They say, "Oh, just scrunch this towel or do these exercises, pick up these marbles," and they just didn't under. I could not move those toes. So, but that day, there's a banister in the room that we were working in, and I just remember just doubling over, just started to cry because I was actually voluntarily I was moving those toes, and that was not anything that I had expected. When I met Court and CJ, and we went on the retreat, I was hoping for some relief of pain. I had no idea the foot would be so impacted the way that it was, and that was just. I mean, to this day, to be able, I'll occasionally just look at my toes and I just can't believe it. At one time, I was asking for that um, to be taken off. I was asking for half of my foot to be cut off at one point, and I thank God I didn't do that now. But my surgeon was actually considering it at the time, that it was an option, not viable really, but because at some point, based on circulation issues, I'd be asking for the whole foot to go, and then up to my knee, and then up to my thigh, and just I'm so glad I didn't do that. And now I don't have full use of those toes, and they're still kind of crunched up a little, but I can spread them out now on my own, and it's just made a world of difference as to the falls. As I mentioned before, going on the retreat, I was falling. I could say stumbles were easily daily, and bad falls were very often. And I was designated as a fall risk in all my medical records, and I got a special band if I went to the hospital that I was a fall risk. And since coming home, I've had probably 3 decent falls, and I'm not having the stumbles. And that's certainly attributed to getting some of my balance back from these toes. How important those other toes are until you're falling down all the time. That's a big part of the reason. And so that was, I was beyond the moon with that. And I just, emotions, I couldn't stop crying.
And I'd like to emphasize, Lynn is not the first vet I've worked with in my career. Very early on, I worked with someone that had returned from being injured in a IED attack in Iraq, and they had developed CRPS in their thigh, from seemingly, it looked like an innocuous injury. And this is a young person, young man, very fit looking, but I didn't know he had CRPS, and it was like day and night burning for him, and he was on all sorts of opioids which were completely ineffective at treating it, and eventually he electively chose to have his leg removed, right? That's the same thing that happened to Albert Lynn in the Albert Lynn case study. He was injured in a rollover accident in I think a Jeep in a desert, and it was still there, but it was mangled. And eventually, like, well, let's just take the leg off. Let's take the leg off because it's got no motor capacity. It's going to take too much effort. It doesn't feel great. But as soon as the limb was removed, he was in intractable phantom limb pain. That's a condition of central sensitization. So a lot of people, when they have these injuries, it's often a loss of signal out there that's driving that pain perception of the brain, and so CRPS can be baffling that way, and can also make other innocuous or coincident injuries far, far worse in their neurological impact. So it was one of those moments where the science, you've heard the testimonials, you've seen it work in other people, you felt it, but you just don't dare believe that it can happen in this circumstance, because it means so much. And then to see it, just all the prep that we put into, like we did a lot of work on that limb and on those toes. We were doing, lots of receptor and peripheral nerve activation, as well as, sensory remapping and things like that. We did a lot to get that ready. So once it started emerging, and this is something I want to emphasize, again, I guess that's my word today, is that there are so many opportunities out there in the treatment world where we see psychedelics are being used for the treatment of pain, and they get that window of analgesic relief, right? Where their pain goes to zero, like in an hour to 90 minutes. And then they're sort of told, okay, move, be free, and things like that. And for some people, that's great. Movement can be incredibly powerful. Free motor expression can be incredibly powerful. But a lot of times, if it's not approached in a systematized, pre-assessed manner, that window closes and they revert back to whatever their previous protective pattern was. So to go from her stepping out of bed in the morning and it being 8 to 10 level pain, to suddenly being able to do multiple, calf raises, toe movement, later that day, her thumb turns on, and she starts being able to picking up silverware reflexively again, not even thinking about it, not even having to stop because of pain, grabbing cups, balancing herself, all these things. It's like, it's important to stress that there's this really rich opportunity in preparation to get ready. And then once that neuroplastic window / metaplasticity critical period reopening, opens, there's so much that can be done. And it was truly one of the biggest joys of my life to be there with Lynn while this was going on, and to have worked in concert with her, and then to be actively reaching back out to, CJ on the phone and you, Joe, for, practitioner recommendations. It's like, I have my wheelhouse. I do have my wheelhouse, but I don't have a complete wheelhouse necessarily. It's like one that I've been working very hard to develop this side of it on. And, I can't emphasize also the difference. Like, Lynn dove in. Once she was on board, it's like, okay, let's try this. And she's like, all right. And then she would do it. Like, patient compliance means everything. And also that she had a care team. Part of her care team at home, her psychologist, was all for this. And like, please, yes, do this. So her, as she affectionately refers to him as her talk doc, and that it's having someone on the care team that has enough understanding the difference something like this can make. But it's just, I want to stress, her numbers radically changed, and they were enduring. So we went from this very active CRPS taking up the majority of her lateral thigh, to shrinking it down to like the size of a dime with no pain and only like a little bit of, numbness or tingling, from very severe debilitating pain. Like, the foot neuromas like disappeared that day, and that was it, and the motor activity returned to her thumb, able to grip and hold and open jars and things like that. And then we had another striking experience with her glossodynia. This burning mouth syndrome is like, it's about as rare as you can get. And it feels like the inside of your mouth is getting scalded the entire, so. And we rapidly discovered there was an incident that happened where there's a close family member. that had been staying with Lynn, and there was a incident with one of her service animals that brought up a lot of stress for Lynn in the middle of a very vulnerable state, you know, as she's going through this on this retreat. And so it instantly spiked her glossidynia, which had been at a 0 at that point, spiked it up to a 10 right then. And like the upset was clear and evident. And there was this brief moment of deep resentment in me. How dare the outside world, you know, interrupt like all this stuff we're doing? But it's like, okay, no, this is what it's going to be like, and here we go. And we had been working on that as well, doing our best to map that area, doing our best to use neuromodulation to intervene. And we did this extraordinary back and forth where we're doing sensory mapping, visiting, you know, these roles that we play within family systems, within our professional roles, you know, how earlyhood childhood events kind of shaped a lot of like our neurological responses, as well as the injuries themselves and the damage to our nervous systems and the alterations. And how, okay, look, we've managed to bring it down over here. We've been using these other tools, and we started like getting into a lot of like sensory mapping on the spot, as well as doing a lot of the breath work that we'd been employing, as well as some other very unique approaches to how to navigate these non-ordinary states of consciousness that have a lot of bottom-up processing to them. So it's a little bit more of IP, but please.
And before we started that, it was immediately from a 0 or 1, and we went up to an easy 8 to 10 in just a matter of seconds. And I made a call back home to see what was going on. Then I got to go take my medicine. I got to go take it. And at one point, this is clonazepam. I had been on 5 milligrams a day of clonazepam for the mouth pain, and I had over the years gotten down to 2.5 milligrams. And at the time I got to the retreat, I had slowly tried to get down. I was down to 1 milligram. And I told Court at that moment, I've got to go take my medicine. It's not going to stop. It's only going to continue to be bad the rest of the day. And he said, hang on. And that's when we did that. And while we were actually in the middle of some of the drills, I got a text message to call back home, and Court said, set it aside. We're here to work on you, and that phone will be, you can make that call in a little bit. And we did, and within half hour, 45 minutes, I was able, with Court's help and learning these new exercises, that I brought it back down. And I can do that today. It's rarely gotten up to since I've been home, over the 9 months roughly, there's been times it's gotten up to maybe a 4 or 5, but I can now have the tools, I can bring it down, and now it doesn't exist. Right now, as I sit here, it does not exist. But I always thought I'd learned to deal with it. It was a stress indicator for me that something was going bad, something was not, it could be the smallest of things. And at one time when I got home, in 1 month, the roof had to be replaced, our seawall had collapsed, you name it, it was being thrown.
Septic tank.
Septic tank was, we were going to have to get septic lines in the yard. And I'm like, we're not made of money. The mouth, being able to control that through all of that kind of stress was big. That was huge. And as I sit here now, for a month or more, it's been at a 0. It hasn't popped up at all.
Well, I'll just say, in the moment, Lynn is reminding me the urgency around the clonazepam and the pharmacokinetic consequence of taking that when someone is in this, and this is probably where CJ is going, so I'll shut up here in a sec. That the consequence of taking, well, CJ, why don't you explain?
So when we're looking at Lynn's medication profile, when going into this, my role is to kind of look at what are you on for medications and how are they going to potentially interact with the medicine. And clonazepam is a benzodiazepine that is used as a trip abortion pill. It'll pull someone out of a psychedelic trip not completely fully, but helping with the situation and everything. So kind of knowing that going into the medicine days, we had to kind of hold out on that medication beforehand. And clonazepam has a half-life of like 12 to 24 hours. So it was like, if you're going to continue this, we want to get this down as low as we can and not be using it prior to the session. And the other piece of that is where, I think Lynn was kind of alluding to was, this is going on in my mouth. I'm experiencing this. How do I know how to stop this? The medication that I have, and just kind of out of habit, I'm going to go to this. And by having that couple of minutes to kind of step back and not directly go into it and using it, being able to see it kind of going away on its own from using our innate healing within ourselves and kind of working on the psychological stuff there to stop that knee-jerk reaction of I'm gonna take this before it gets worse. And there was other medications, like I had mentioned, the antidepressant medication that we were looking at, which is why we ended up doing like an assessment dose, and we can mention that here in a minute. And a couple of the other medications that were there was, let's kind of clean up your med profile, because many times I see from working with REMAP and my normal job that I'm at, people have this polypharmacy that's going on, and people are on numerous medications, and sometimes it's like, well, I have this side effect, so we add and we add and we add, and it's not often having a chance to start deep prescribing and starting to take some stuff away. And people have sometimes been on medications for years, and I don't even know if it's doing anything anymore, but I'm afraid of stopping it. What am I going to look like here? And that's a conversation I have, daily with my patients is, okay, let's kind of go down and we'll see how you're doing without it and kind of see, because, we get on these meds and we know how bad I felt beforehand, but then someone might be on something for 10, 20 years and not knowing what it's going to look like. So it was kind of one of those concerns there. Was there something else you wanted to mention on that, Cord, or do you want to go into the assessment dose stuff?
So just that in that specific circumstance, the quality of the multifactorial approach, I don't think can be overvalued enough. That we're dealing with current psychological circumstances, current neurophysiological circumstances. We're doing psychological intervention, though I should stress I am not a therapist. Okay. So, we're looking at adverse childhood events. We're looking at what are the neurological responses going on right now? What's going on in terms of, autonomic regulation here? Are we upregulating? Are we downregulating? Things, all of those things are, just ever present. But honestly, the clonazepam, it can be a profoundly beneficial drug for so many things. In this circumstance, we absolutely did not want to close that neuroplastic window that was induced by the psilocybin. It was crucial that we keep that open for as long as possible, and knowing that half-life was there, and having seen the remarkable results that had happened the day before, and that were persisting at that point, it's like, no, right? And as CJ's saying, I'm not saying it's a psychological crutch, but there is a psychological association, right? And that neural chunking that gets also reinforced each time you take that medication, right? So those are all present. So, then we move forward into like this, next dosing day, that's, looking to really clear, we've done our assessment dose. So now we're going for a larger neuroplastic dose where we're trying to move as much of the onboard inflammatory burden, as well as in terms of adverse, nosoplastic responses. We're trying to do a lot of earth moving at that point. and
And
and then everything that we've been building up really kind of coming to a go ahead, CJ.
well, before I want to mention like what we did is we did three dosing days over this week that we working with Lynn, and part of the challenge we're trying to figure out was what do we want to do for a loading dose, a starting dose to kind of do an assessment dose to see how is she going to respond with going into this expanded state of consciousness, being psychedelically naive, and at the same time, what is her response going to be because of the antidepressant there? Um, as we were doing, looking at what she's on for her dose, from my experience, both professionally and working with patients within my practice, I've seen people who have gone in and done high dose psychedelics, doing the 3.5 grams, go in and being diving into a pool head first, basically, you know, um, very, very challenging, very, very difficult, and didn't want to have that, have Lynn have that experience, but also not knowing what is her response going to be with the antidepressant being there. Research is out there. Sometimes it can kind of mitigate some of the effects, sometimes not. And in the back of my mind, I'm thinking of one of my patients I see in my practice who, she was on the same antidepressant, and when she went to a facilitator who I know and trust, this facilitator, I didn't know that she was going and seeing them until after, but she was on this antidepressant, and without talking to me, she went in and they thought that the medicine was blocking the effect, so she took more medicine and took more medicine. At the end of the day, she ended up taking about 10 grams of psilocybin. And in doing that, the medicine, she had her own trauma history and could not let go and kind of let the medicine do the work. Um, and as a result, the medicine just started stacking up until she had no choice and couldn't hold on. And she had a very fucking difficult experience that she had. And as we were kind of talking about it post, she's like, had I let go, I wouldn't have gotten that. I wouldn't have taken that much medicine. And I probably didn't need that. So I wanted to kind of, ease Lynn in. So we went with a moderate sized dose to kind of begin with, knowing that we can always take more. So she took her moderate sized dose and kind of like looking at like the MAPS protocol for MDMA, you can always take more. So after about an hour, hour and a half, she took another booster dose to go a little bit deeper and kind of ease her way. Sorry for the pool analogies, but kind of like waded into the pool and then kind of went a little bit deeper instead of jumping in head first. And it wasn't as difficult for her. With knowing that assessment dose and how she did when we did the high dose day subsequently, she took a higher dose and then also re-upped in that to kind of ease into it as well. And I think that for some people, the medicine does the work, but also having that neuroplastic window opening and being able to almost have like being a psycholytic dose where it's not fully psychedelic at the beginning, to kind of have some interaction and kind of talking and just kind of loosening things up, similar to maybe someone having a drink or two of wine before and kind of feeling loose and feeling a little bit more free and kind of out of that conventional difficult area for her.
And when it comes to chronic pain and so many other things, but chronic pain especially, threat modulation is a key point of understanding here. Whereas bizarre as it sounds, chronic pain is actually a protective response from the central nervous system that's just gotten overclocked, over entrenched. And it's like, how do you approach this in such a way that someone who is psychedelically naive, right, feels comfort and security in going into that experience? And then, you want to introduce success repeatedly, even in small doses, so that familiarization is taking place, right? And then as that increases, that allows somebody's comfort zone to expand and willingness to maybe expand the range of where it can take you. And the discovery, as Joe, as you know, probably more than anyone, the discovery in the moment right? When you really dive into the deep end of the pool, or perhaps get into a bathysphere, it what can be brought up from the bottom can be shockingly, profoundly transformative, and that this is all happening within this, in the realm of our, you know, the totality of our neurological experience, right? And that these aspects, I'm getting a little out there. These aspects that maybe are well outside our ordinary daily experience can have such a huge impact, and being prepared for those, it just makes all the difference. But I don't know. I think just maybe kind of wrapping up here. Um, Want to just emphasize, like, at the end of the day, so Lynn's glossidynia, like in terms of frequency, the number of times that it would happen decreased by 75% per month. The intensity decreased by 75%. And the duration per episode decreased by 75%. And she could, it used to, correct me if I'm wrong, Lynn, but episodes could last for days for you, right? When you had it
Oh yeah.
prior
Yeah.
to yeah. And then now we're talking about you being able to take control and immediately start self modulating, and it's back under control and down to 0 or zero point 0.5, like within
Right.
half an hour. And,
Yep.
that's happening only a couple times a month versus like way more than that. And the difference in the fall hazard, like decreasing the number of falls plummeting the way they did, it can't be overstated. Like, that is not to overstate it, honestly, that's a death risk right there for many people, or can lead to severe neurological trauma from head injury. And as walking is pretty fundamental for us. And like, if you step out of bed and the first thing you associate with standing or moving is like, this is going to hurt about as bad as stepping on a nail, right?
Right. Yep.
And then walking with the nail in your foot, and not being able to have motor control. So it's one of these things where, once again, all the evidence was there beforehand. These approaches have been developed beforehand in separate fields, but being able to synthesize them together, and just by trusting the science, trusting the pragmatic institutional knowledge that's been developed out there, both within the underground communities, as well as the chronic pain, as well as communities like Cluster Busters, and like, these people aren't out there making up stories about this efficacy. It's everywhere. Well, so just thank you to everyone for listening to us today, and my profound thanks to Lynn, Lieutenant Colonel Lynn Watkins, for putting herself in our hands, and then being like an active, fulsome participant in her recovery. And just seeing the change that's happened since has just been truly one of the hugest gifts in my life.
And I'm the one that thanks you guys. I feel like I'm 30 years backwards in life before all this started to snowball. And that snowball just became so huge, and so many doctors and so many medicines and so many adverse effects. And to now be I'm off of so many medicines now. I have a few more I want to get off of, but I don't have enough positive to say. I just thank all of you, all three of you.
There, there's a couple of things just to wrap up. I want, just for full closure here. I mean, when we're looking at the MADRS scores, well, like I said, there was like 41 when we started. Her follow up, it was 0. Her HAM-D went from 22 at the 1 month follow up. It was 2, and I hate to say, but those 2 were like almost a false positive because of part of the change that we have part of the REMAP model is integrating diet and diet changes and getting off of inflammatory foods. And I think it was avocados and something else that Lynn found that she liked eating there, that she ended up really
Cherries.
liking.
Cherries.
Okay. And a couple of those things had increased appetite, but it was things that she was starting to like to enjoy. So that counted against her CAP score at 1 week was 21. As started integrating down from a 54. Like I said, there's a lot of things that had happened, like the wall and the septic tank, that kind of kept it up. Family was staying with her for the time during that time, but at 1 month, her CAP score went down to 3. And one of the other things that I know was mentioned in the webinar was Lynn had inadvertently forgot to bring her Butrans patch to help with pain, and she detoxed from that inadvertently during the process and came off of that completely, which was never something. It was a happy accident, which
like effortlessly. We thought it was just insomnia driven by the psilocybin and the fact that we were up in a mountain pass. And by the end of that week, in the brief pain inventories that we were taking, and we took multiple brief pain inventories that like kept dropping and dropping, there was a noted improvement in her sleep. And she so a couple nights of insomnia, but towards the end, she's sleeping the night through. And honestly, she thought it was because she wasn't having to wake up to take out her dogs. It's like that's noted on there. So
huge.
And in this final wrap up, it's also important to note, we also gave her the mystical experience questionnaire, and I believe she got 131 out of 150, which is very significant. And it was a profoundly transformative and transformational moment that I had the privilege to be part, in witness of.
Well, thank you all for sharing. We've got a wrap here, but we'll have a lot of info in the show notes if people want to follow up. Everybody, please check out psychedelicsandpain.org. And again, thank you all so much for being here.
REMAPtherapeutics.com.
Yeah, and check out the Microdosing Guidebook. Absolutely. All right. Thank you all, and can't wait to do more.